Good evening, everyone, and welcome to tonight's webinar, Targeting the Mechanics of APDS to Help Restore Immune Balance, sponsored by Farming Healthcare. We're excited because this is the first national webinar to discuss both APDS and the first and only FDA-approved treatment for APDS, Joenja. Tonight, we have the distinct pleasure of hearing from Dr. Nicholas Hartog. Dr. Hartog is at the Helen DeVos Children's Hospital and Corewell Health West Medical Group in Grand Rapids, Michigan. He specializes in pediatric and adult allergy and immunology, where he serves as the head of the Adult and Pediatric Primary Immunodeficiency Clinic. He is also a clinical assistant professor at Michigan State College of Human Medicine. Dr. Hartog's clinical interests focus on primary and secondary immunodeficiency, but also include allergic rhinitis, food allergy, and treatment of severe asthma. Dr. Hartog has authored or co-authored more than 30 publications on immunodeficiencies, food allergy, and COVID-19. He is a member of the Clinical Immunology Society Education and Advocacy Committee. In addition, he is also an active member of the American Academy of Allergy, Asthma, and Immunology Primary Immunodeficiency Committee. Without further ado, I will turn it over to Dr. Hartog.
Thank you, Don, and thank you for introducing me, and thanks everyone for being here tonight. I'm very excited for this webinar, and the goal today is talking about Joenja or leniolisib, and really talking about the disease state, its mechanism, and how this new drug can really help to restore immune balance in this disease.
Indications and usage. Joenja, leniolisib, is a kinase inhibitor indicated for the treatment of activated phosphoinositide 3-kinase delta PI3K delta syndrome, APDS, in adult and pediatric patients 12 years of age and older. Important safety information. Verify pregnancy status in females of reproductive potential prior to initiating treatment with Joenja. Joenja may cause fetal harm when administered to a pregnant woman. Advise patients of the potential risk to a fetus and to use highly effective methods of contraception during treatment with Joenja and for 1 week after the last dose. Additionally, advise women not to breastfeed during treatment with Joenja and for 1 week after the last dose. Live attenuated vaccinations may be less effective if administered during Joenja treatment. Joenja may cause hypersensitivity reactions, including anaphylaxis. Advise patients to discontinue Joenja and to seek immediate medical attention if they develop any signs and symptoms of serious allergic reactions. Use of Joenja in patients with moderate to severe hepatic impairment is not recommended. There is no recommended dosage for patients weighing less than 45 kilograms. Avoid co-administration of Joenja with other medications known to be strong CYP3A4 inhibitors, strong or moderate CYP3A4 inducers, or BCRP, OATP1B1, and OATP1B3 substrates. The most common adverse reactions, incidence greater than 10%, were headache, sinusitis, atopic dermatitis, and weight gain. 33% patients receiving Joenja developed an absolute neutrophil count, ANC, between 500 and 1500 cells per microliter. No patients developed an ANC less than 500 cells per microliter, and there were no reports of infection associated with neutropenia. Before prescribing Joenja, please read the full prescribing information.
So the goal of this talk is to give a big, broad overview, starting by talking about a case study, and a case study that really highlights a lot of different aspects of APDS. From there, going into an overview of APDS in general, talking about the clinical trial results of Joenja, and then talking about the available access and resources that are available for Joenja. So we start out with this case, and a case that I'm sure a lot of you on the call have had very similar patients. The chief complaint that you're getting ready to look at this patient, getting ready to see him, is bronchiectasis and lymphoproliferation. And then that's really what brings her to the clinic for you. And somebody had done a high-resolution CT scan that showed that bronchiectasis showed some mediastinal lymphadenopathy. When we go and look at a little bit more detail of her history, we see a lot of things. We see early in infancy, she started having frequent respiratory tract infections. And she also had occasional labial HSV infections, which is, quite odd for a infant and a child of that age. Then we start noticing some signs of lymphoproliferation, some not a big deal, when taken by themselves, like an adenoidectomy. She had an adenoidectomy at age 7. Plenty of kids have an adenoidectomy. However, she started having persistent lymphadenopathy of the cervical region that around about age 12, and that it really just didn't go away, and it really did persist. Then at the age of about 24, she started having multiple biopsies due to suspicion of cutaneous lymphoma. And she continued to have diffuse lymphadenopathy that never showed any clear malignancy and just showed benign lymphoproliferation that wasn't quite normal, but also didn't reach the level of any concern for lymphoma. She also had continued splenomegaly that was noticed. Then that brings her to where somebody said, with all of these recurrent respiratory infections, maybe we should do a CT scan. And so that showed prominent bronchiectasis. And when I start thinking about immune deficiencies in general, inborn errors of immunity, this is one of the things that's very important for me to know is I want proof that people have had severe recurrent bacterial infections and not that they just have had recurrent URIs, they have uncontrolled asthma. For me, bronchiectasis without another or an alternative cause is a big deal. And that's a big red flag for me. And then she also had mediastinal lymphadenopathy. Now, then we circle back around, and she had a 5-year-old son. And when we take the family history, we find out that that 5-year-old son has had a lot of things. He's had recurrent respiratory tract infections, some lymphoproliferation. He's also had bronchiectasis, and eventually was diagnosed with some nodular lymphoid hyperplasia. And then that 5-year-old son was diagnosed with APDS. And when we look at the details a little bit more, in addition to the history I gave you, he had a mildly decreased IgG, nothing red flag or remarkable. But when we look at the response to vaccines, he did have a decreased MMR response. And he had a marked activation of both CD4 and CD8 T cells with a flipped ratio. And he has history of EBV infection. No persistent EBV viremia, but when we look at his titers, he really had a decreased humoral response to the EBV, despite a documented EBV infection. Based on that, there was an additional workup done that did diagnose APDS with that genetic variant is one of the first and most common reported genetic variants. He was treated with prophylaxis, immune replacement therapy, and had an excellent effect and really decreased infection susceptibility, but really didn't have a huge effect on his lymphoproliferation, and that continued to go on. So based on that, with that family history, knowledge that APDS, as we'll talk, is a autosomal dominant disease, there's one of two situations. Either this child had a de novo variant, and he was the first one in his family to have that, or it was inherited from either mom and dad. So it does make sense to go and to go search and do more genetic testing on the family, especially when you have mom with this type of history. And so that's what they did. They noted that mom had a decreased IgG2 and IgG4. Then when we looked at the function, she had a poor response to polysaccharide antigens. And so most commonly how we do that is the pneumococcal antigens, and then also a poor response to MMR. And she really just had a similar immune profile as her son when we start to look at all the details and go a little further in depth. And that did include elevated plasmablasts. Because of this, she was also diagnosed with APDS, and genetic testing revealed that she had the same disease. She was started on immunoglobulin replacement therapy, and she was also enrolled in the Joenja phase 3 trial at that point. And we'll talk about her results from that in a little bit later. And this really highlights whether we started with the mom or started with the child, how family history and family genetic results can really help impact the workup for patients like this. So with that, one question I have to just poll the audience and start trying to get everyone involved, because that's one of my goals, is getting everyone involved here, is, has anybody here on this call seen a patient like this? And there we go. Poll is going to come up and you can answer away. All right. So we got about, this is interesting. We got about 50-50. About a half of you guys say, yep, I have, and about half have said, no, you haven't. And hopefully by the end of this talk, we'll talk about all of the various ways that it can present, and we'll see that perhaps more of you than 50% have seen a patient that we should think about. And so when we think about this patient in particular, is there any kind of workup that all of you would have considered prior to doing genetic testing? And we got another poll here. And I should say, if you have other, please put it in the chat and we'll do that. And I should be able to see it. All right. So we got a couple of things. And so CBC with diff, yes, absolutely. I would say a CBC with diff is an essential first line. I definitely agree with that. And in fact, you can't get the lymphocyte subsets without a CBC with diff. And if you don't order it, the pathologist will just do it in the background to get it. So, and that really, a CBC with diff can give you a lot of different information. One, it can look at your overall white blood cell count, which can be of varying significance. Sometimes we have neutropenia, sometimes we have lymphopenia. And then it can look at your overall red blood cell count, your hemoglobin. Various anemias can present this way, and then also your platelet counts, and things like ITP, autoimmune hemolytic anemia, are things that we need to be aware of. And then testing for secondary immune deficiency, absolutely correct. Well, I said that bronchiectasis is concerning and catches my eye. If we don't have an alternative explanation or diagnosis, we need to look for that alternative explanation or diagnosis. And I'll tell you, for me, most commonly, I'll get an unexplained bronchiectasis referral. It's not from primary care, it's from pulmonary. Pulmonary who did the workup, who did HIV, cystic fibrosis workup, ENT who did a PCD workup, and it's negative and they don't have an explanation. All that needs to be done, so perfect. All right, and then thinking about this, when would all of you here have initiated genetic testing? All right, so we've got a little variant, and so nobody would have done it right away after the recurrent infections. I think that's fair. You need a little bit of evidence that something deeper is going on. We see lots of people who say they have recurrent infections. Benign lymphoproliferation would be a trigger for some. After the immune workup, we said, hey, we have a suspicion for an immune deficiency, and we have some decent evidence that one does exist. I think that's very reasonable. And looks like everyone, at least who answered, would have done some genetic testing, which is, I would say, encouraging. All right. So the genetic testing, it can confirm or does confirm a diagnosis of APDS. As we'll talk, there are a lot of inborn errors of immunity that can present with a variety of ways and can present with overlapping symptoms. And we really say inborn errors of immunity these days because of diseases like APDS that present with immune dysregulation at its heart. One of the amazing things is APDS was first characterized end of 2013, beginning of 2014. When we think in the grand scheme of things, not that long ago. And there are two papers published about the same time, one in Science, one in the Journal of Experimental Medicine, that two different groups who published their findings here. And that in the grand scheme of things, this is one of the first really big CVID variants that I think caught a lot of press and caught a lot of attention. When we think about it, and if anybody was doing genetic testing back at that time in 2013, it was hard to get genes. The panels really didn't exist. And if the ones that did were pretty small, not inclusive, and they were extremely hard / impossible to get covered by insurance. And so genetic testing really didn't become easily commercially available for APDS until about 2017, so not that long ago. Then when we think about it, We have a few different modes of inheritance, as everyone on this call should know, but APDS has an autosomal dominant inheritance. And so when one of the parents has it, so in this case, it's dad, there's a 50% chance of it being passed down to the children. And 50-50 between males and females, it really doesn't matter. There isn't a predilection there. And so if we look at this theoretical family who has 4 kids, 2 males, 2 females, play your odds, one of the males, one of the females will have APDS. But a couple things to keep in mind. One is it can happen de novo. And so you can be the first person in the family to have it. I've got, I think, 2 patients of mine are de novo, and we've documented that. But then the tricky part is in immune dysregulatory diseases, specifically APDS being one of them, the autosomal dominant one, is there is a concept called variable penetrance and variable expressivity. And what that means is it really is hard to pin down and say everybody in a family, even with the same genetics, is going to have the same symptoms, the same presentation. And a lot of these diseases, APDS included, of the immune dysregulatory type, present really differently. And you'll take a big family and that you've documented everyone has the same disease and look at their manifestations, and it really can be confusing. How can this be the same disease in the same family? And it's because we really can have a variable presentation. And while we'll talk about the long list of things that can happen in this disease, it does not mean that everybody in the family, it will happen. And so when we talk about genetic testing in this way and getting genetic testing, it seemed like at least everyone who answered the initial question would get it. But what kind of barriers exist that would prevent you from getting genetic testing? All right. And so a couple things I think we got to kind of all over is that there's a lack of insurance and cost of the patient. That's a huge issue. Hopefully that's starting to get better, but it absolutely is something to consider. Uncertainty in interpreting the results. Genetic testing is tough to interpret, and it can be at times. And again, there's hopefully ways that are getting better at it, and we can have positive, negative results. We can have a whole lot of in between. The turnaround time can be long, and when I talk to patients about when to expect their testing results, genetic testing is absolutely the one that takes the longest. Although most methods we use now, short of whole exome sequencing, 3-4 weeks for turnaround time. And then, some people say there's no barriers. And I love seeing that, because that means that the appropriate people are hopefully getting the genetic testing to be able to get targeted treatment. Now, with that, and we talk about these barriers, what factors would make it easier for you to integrate genetic testing for family members? And you know what? It looks like everyone's saying about all of the above, which is probably appropriate. So we assist with the cost. Yeah, it's going to be easier. Assistance with interpretation of the results, access to genetic counselors. I don't know what everyone else's situation is. I don't have any genetic counselors in my clinic, and by that fact, I'm the de novo genetic counselor, or the de facto genetic counselor, I should say, and that presents some challenges, and it does present a higher bar, but having access can absolutely make it easier. And then helping patients understand, why do we need to test? I think all of those are good, reasonable answers, and it really is across the board. And I think that I would definitely agree with what we're seeing there. All right, let's go to the next slide here. So the signs and symptoms of APDS can really vary. And if we were in a room together, I would challenge all of you to point to a spot on your body and find somewhere that APDS can affect. It really can affect everywhere. Now, obviously there's places and there's parts and there's organ systems that are going to be affected more often and more frequently, and things that should tip us off. But it really is a systemic immune dysregulatory disease that presents with immunodeficiency and autoimmunity, and some variation of both of those depending on the patient. And that's where the term immune dysregulatory disorder comes from. And when we look at it, it almost always, I shouldn't never say always, but it usually presents with more than one symptom too. And so that's another thing that can kind of tip you off, is if you see some of these complications starting to stack up, maybe we should think about, hey, could this be APDS? So I'm going to start at the top right and kind of go through all of these and talk in a little bit more detail and spend some time on this slide, because I think this is very important to talk about. So severe recurrent sinus pulmonary infections in 96 to 100% of the cases. So nearly all, depending on which cohort you want to believe, and probably some of that, some selection bias is how they identified the cohort and all of that. But at its core, a humoral and really a combined immune deficiency, because there is a T cell deficiency in this, and we'll talk about the T cell defects, are at the core of APDS. Most often, this presents as a CVID-like disease. And I emphasize the like because all of them will not meet the diagnostic criteria for CVID. And if we look at the original two patients, the younger patient, the IgG was just slightly low. We don't have the exact number, but I doubt that would meet the diagnostic criteria. And then this mom only had a low subclass, which would not meet the diagnostic criteria. But a lack of response to polysaccharide vaccinations is key, and then those sinus pulmonary infections. Neural development delay can happen in 10 to 30% of patients, a little bit more common in APDS too. And then we can have autoimmune and autoinflammatory diseases. This is super common, and take your pick of various autoimmunity, and it can happen. And take your pick of autoimmunity in various organs. Autoimmune cytopenias, and so like I talked before, autoimmune hemolytic anemia, autoimmune neutropenia, ITP, absolutely can happen and are very common, up to a third of the cases. When we look at these autoimmune cytopenias, especially when we have it in more than one cell line, in especially kids, that really should raise our suspicion for an immune dysregulatory disease such as APDS. Lymphoma is very, very common, 10 to 25% of the cases, or 12 to 25%. 25% rate of lymphoma is incredible. We know that patients with CVID are at an increased risk for lymphoma in general. By the USID net, that's probably about 4 or 5% of the patients with CVID, which that's an incredibly high risk. And so even if we take the patients with CVID that are high risk, they're even higher risk than just general CVID. And it can present with lymphoma as the first presentation, and that absolutely can happen. Enteropathy is common. We can have inflammatory bowel disease. We can have a nodular regenerative hyperplasia in there. Severe persistent herpes virus infections. This is something very specific, and it's something that should be emphasized. Herpes virus can be HSV, but it also more commonly can be EBV and CMV. These are patients that can get EBV and CMV disease that can be severe. They can also have chronic, legitimate chronic EBV and CMV, not kind of what also always is blamed on it, but they can have a persistently positive viremia. And this is one of the reasons that, and for me personally, in all patients with CVID, I do check a baseline EBV and CMV PCR, because that can give me a hint to some of the diseases that have trouble controlling herpes viruses infections, like APDS. Failure to thrive, a lot of immune deficiencies in young kids have that's on the differential. And then when we circle back around, this lymphoproliferation, and this is why I'm kind of ending with the, well, bronchiectasis too, but I want to emphasize the lymphoproliferation as what I end on here is lymphoproliferation is huge, whether it's the lymph nodes, whether it's the spleen, whether it's the liver, is having a benign lymphoproliferation with a very distinct pathology on biopsy that just looks disorganized. It is very much a big finding in this disease, and is found in majority of patients at some point. Sometimes it comes and goes, sometimes it's persistent. And we really don't know the connection of whether it's triggering for lymphoma or not at this point, and when it tips over to the lymphoma. And so it's something we need to know more about, but it's very, very common in this disease. All right. So when we talk about this, we have all of these findings, but then when do they present? And so this is, if we look at the data out there, this is going to be your most common age of presentations for some of these complications. Now, I need to emphasize most common because each individual patient can do whatever they want. They can have a malignancy first at age 3. They can develop bronchiectasis earlier, so on and so forth. And so we usually see start of infant infections. We start where we see humoral immune deficiencies. Then at some point in early childhood, preschool age, we start seeing benign lymphoproliferation, enteropathy, chronic diarrhea. This is a question I ask is, do you have chronic diarrhea, blood in your stool? Do you ever really have solid bowel movements? Then we start seeing autoimmunity present, and then bronchiectasis. And this bronchiectasis isn't because of APDS, it's a secondary finding. And so it's because we've had recurrent severe pulmonary infections. We start having scarring in the lung because things haven't been diagnosed. And unfortunately, in patients not only with APDS, but immune deficiency in general, we really have a delay in diagnosis. In APDS, on average, it's a 7-year diagnostic delay. And then usually in late teenage years to early adulthood is when malignancies present, and when lymphomas present if they're going to, and when we need to watch out for that. But like I said, it can present whenever it wants. Then when we think about this, is not only is there a diagnostic delay to diagnose APDS, but when we look at immune deficiency in general, there really is a diagnostic delay. And I think if we take CVID, the last statistic I saw was, depending on which survey you want to believe, between 10 to 15 years from the onset of symptoms to the diagnosis of CVID. And when we look at the other things this has been called, before they're eventually diagnosed with APDS, it's all over the place. We have some humoral immune deficiencies such as XLA, we have CVID, we have IgG subclass deficiencies. Just recurrent infections. We have some that were a combined immune deficiency, which is, I would say, pretty accurate. Some that were diagnosed with a lymphoma first, and lymphoma is really the presenting symptom that made people think of it. We have ALPS because of the benign lymphoproliferation, and so genetics negative ALPS because it's not one of the classic genes. And then a big majority of patients that were diagnosed as just a generic hyper IgM syndrome. And this should be emphasized because when we look at some of the mechanism of what's wrong on a cellular level, it does induce a class switching problem. And so we do notice that patients have a higher IgM on average, not all of them, but on average. We'll talk about some of the immune defects here. Now, when we look at details, and when we start looking at the immune phenotype, we see a lot of different things. We see an elevated CD8 effector and memory T cells, increased senescent T cells, increased transitional B cells. Then we also see this increased IgM, as I mentioned, because of this class switch defect. And this isn't all patients, and I can tell you that some patients occasionally will even have a low IgM, so that's pretty uncommon. And then we also have this inverted CD4 to CD8 ratio that can be pretty pronounced. And then when we look at what's defective, we have decreased naive and CD4 T cells, decreased B cells overall, decreased memory T cell function, and then decreased memory B cells, and then decreased IgA and IgG, which helps often get to the diagnosis of CVID. This immune dysregulation, what does it lead to? It leads to immune deficiency, immune dysregulation and deficiency, and just immune dysregulation in general. So immune deficiency, we have sinopulmonary infections from the humoral part. We have these herpes virus infections, and that's more the T cell compartment. And this was where we get the combined immune deficiency. We see bronchiectasis, lymphoma, enteropathy. And then the immune dysregulation by itself, we have this lymphadenopathy, we have splenomegaly, we have hepatomegaly, the enlarged liver. In the autoimmunity, we see cytopenias, those autoimmune cytopenias, autoimmunity in general, and autoinflammatory disorders. All of these put together make up APDS, and these are really the immune reasons of why that happens. Now let's look at a little bit more detail. And so this is all of what we talked about on the last slide is due to B and T cells being dysregulated to PIK3 delta pathway hyperactivity. And what happens is we have two units of this PIK3 delta subunit. We have the P110 delta, which is constitutively expressed and activated, and then we have the P85. This P85 is a break. And so when P85 is defective in APDS2, it's a release of the brake. And so that's how, if you drive in a car and you release the brake, your car is going to go. And that's how I look at it. And then P110 delta or APDS is an overactivation. And what that leads to is phosphorylation of AKT. And when the PI3K delta is activated, it leads to mTOR overactivation and inhibition of FOXO. And so these work and play back and forth, and the proper regulation of the immune cells requires an interplay between activation and inactivation of the FOXO and the mTOR working together for immune regulation. What all you have is an overactivation of mTOR and an inhibition of the FOXO. What we get is this apoptosis inhibition, proliferation, and survival advantage, and then differentiation and problems in that. And that's where we get some of the lymphocyte subset abnormalities that we see. And this leads to complicated downstream effects because of this. And all of this leads to lymphocytes not developing properly, not going through their proper developmental stages that just, in the end, wreaks havoc on our immune system, causes everything that we're seeing in this disease. Now, when we look at this, we've talked a lot about kind of a patient, how we can present, and now the molecular ways. When we're thinking about this now, do any of you have patients with a constellation of clinical symptoms that resemble APDS, as we just talked about? Okay, so we have a majority that say, yeah, we've got some people that definitely look like this, and it's hard to pick up on these sometimes if you're not thinking about it. So it's good to get it in your mind. Now, after learning how this can progress, and thinking about patients you've had with persistent lymphoproliferation, is there anything that you would do differently with those patients? Okay. And biopsy to assess for malignancy, I think that's key. And that's when we see this lymphoproliferation, well, I say a lot of it's benign, we have to make sure it's benign. And even if it's not benign, it doesn't rule out APDS, it just can also be a lymphoma. Perform an immune workup and order genetic testing too. And I think all of this is key. And I've really worked hard with our pediatric hemonc group to exactly these ALPS type patients, or these benign lymphoproliferation type patients, send them to us and help us to do an immune workup looking like this. All right. And then also thinking about that, back to genetic testing, be more likely to consider genetic testing for the patient's family members based on what we've just talked about. And yes, it looks like, yeah, a lot of people would change what they do and what they're thinking about, which is fantastic. That's hopefully what we want to do, is to change some patterns here too. All right. Now, when we talk about Joenja, it's the first and only treatment specifically indicated for APDS. It was designed to correct the underlying immune defect in APDS and to help normalize the hyperactive PIK3 delta pathway that we just talked about. And so Joenja is designed specifically to inhibit the P110 delta subunit. And it really has a very high specificity for that subunit and helping to regulate this pathway. It's recommended administration, what it was just approved as, it's an oral medication. And so it's 70 milligrams orally, it's twice daily, about 12 hours apart. And in both adult and pediatrics over the age of 12, and weighing over 45 kilograms. And again, that 45 kilograms, the reason for that is that's what it was studied in. And so we really have a lot of confidence that they do need to be over that weight to know that the pharmacokinetics work out. And Joenja is nice that it can be taken with or without food. We don't have to worry about getting up in the morning to take it before. It doesn't matter. The pharmacokinetics work out either way. When we think about it is the evidence behind Joenja, what was it? And so this is a rare disease, and so doing these trials can be difficult, but they can be done. And so they started out with a phase 2 trial, non-randomized. There's a dose-ranging trial, 6 patients with APDS, 12 weeks. They did 10, 30, 70 milligrams twice a day and 4 weeks at each dose in order to do pharmacokinetics. Based on that trial, they did select 70 milligrams twice daily as the dose to go with. A phase 3 trial, and this was efficacy and safety and evaluation. So I want to emphasize this is a randomized, triple-blinded, placebo-controlled trial. If you look in immunology, you have to search pretty hard to find very many randomized, placebo-controlled trials for medications. And so I don't want to understate the importance of this. And so what they did is they took 31 patients with APDS. 21 were given Joenja, 10 were given placebo. There's a 12-week trial. Everyone got 70 milligrams BID. They had 2 primary endpoints. One was the change from baseline in the log-10 transformed index lesions. And so that's the index lesions of lymphadenopathy. And so this is a way that they measured a lymph node and said, did it decrease in size? And then we also addressed the percent change from baseline. Also, another primary endpoint was the change from baseline in percentage of naive B cells out of the total percentage of B cells. And there were some secondary and exploratory endpoints. We'll talk about all those. And then also they looked at safety. Finally, the last part of the trial is open label extension. So they took everybody and they offered it to all 37 patients from these first 2 trials. And then they also had 2 patients that were enrolled from previous trials of investigational inhibitors that didn't work out. And so they ended up with 35 patients, 37 patients in total, 35 and then 2 in this open label extension that's ongoing, and they continue on 70 milligrams twice a day, non-randomized, open label, long-term. Really, the big thing is long-term safety, tolerability, pharmacokinetics, looking at this. When we look at the baseline characteristics for the Joenja and the placebo trial, they really are pretty similar. We have people average age in their 20s. In both, we have kids in both the placebo and the Joenja side. We have adults in both sides. We have a pretty even distribution among males and females. And baseline steroid use is pretty stable. Baseline immunoglobulin replacement therapy is pretty similar. And then whether they were using rapamycin or sirolimus at baseline is also pretty similar. So no major differences between the groups. And when we talk about some of the prednisone, is they were allowed to have up to 25 milligrams daily of the prednisone was permitted before they tried. And then the sirolimus, they also had a washout period of 6 weeks before they started the trial. And so they did have to have that washout before. So it wasn't that they were giving both of those at the same time, which I think is important to note. Now, when we look at the results for the co-primary endpoints, and there's a lot of things. They look at this index lesion as a proxy of immune dysregulation. In between the first and the 6th largest node that was identified, the index lesion. And so it was thought to be a representative lymph node for everything. What they see is that in the Joenja trial, there's a 46% decrease in the size of that lymph, or percentage decrease. And that p-value is very significant from the placebo endpoint. And if we use what the actual endpoint was, this log-10 transformed index lesions, we also see a statistically significant decrease. And when we look at a CT scan of one patient, we can see, like right here, this lymph node has returned to normal size after 12 weeks of the Joenja. Then several patients with some of these lymph nodes too did notice decreased neck soreness, decreased difficulty swallowing. And so some things like that were noted by patients after taking the Joenja for 12 weeks. When we look at the change of naive B cells, we see that there is an increase in the naive B cells for patients with Joenja versus the placebo. And again, this is very statistically significant. When you look at some of the ends, I do want to point out that the ends are different here. And this is because some of the patients were excluded from this analysis because they didn't have a low enough percent of the naive B cells at baseline. It was above 48%. And if we include those patients and just look at the increase, it does still remain statistically significant. But for the primary endpoint, they did only include these people in that. We look at some secondary endpoints. We look at the spleen size, and this is again a kind of a look at lymphoproliferation, and we see that at week 12 there's a 27% decrease in the 3D spleen size reduction. And when we look at a couple patients specifically, we can see that this decreases down to a normal size. And that mean 27% reduction is just huge. And we can see that a lot of these patients came down to the normal range, but most all of them, the spleen decreased at some point, or decreased just in general. Now, one exploratory analysis, and they looked observationally at the reduction of IgM, and that they noticed with the Joenja that the IgM did decrease to the normal range on average in these patients after the 12 weeks. What this means and kind of going long term is, I think, unknown, but I do think that this is a really interesting thing, knowing the molecular defect and knowing that this is a class switch recombination defect at its heart. It is interesting to note that this observation is being seen. I think we need a lot more data to say, is this, what's the significance of this? But it is something that we definitely want to take note of. Now, safety profile, and it was a very well tolerated medication. And in the phase 3 trial, a majority of the patients did have some adverse event. It was about 74% had a grade 1 adverse event. And it was study related in about 8 patients. None were serious. And the adverse events was actually lower in the Joenja arm than it was in the placebo arm when we look at it. Really, the most common were headache, sinusitis, and a dermatitis, atopic dermatitis in particular. The dermatitis has been observed previously as a class effect of PIK3 inhibitors, and so that should be noted there. Then when we look a little bit further into the open label extension, so 32 out of the 37 patients had more than one adverse event. However, the majority, 78%, were grade 1, about 48% were grade 2, but then none were deemed to be serious. And there's no serious adverse events related to the Joenja. When we look at the most common things, upper respiratory tract infections, headache, pyrexia, otitis externa, and then weight increased in a few of them. And then one patient did have baseline cardiovascular comorbidities, suffered cardiac arrest and death at day 879. It was determined to be unrelated to the investigational drug at that point. And right, and I should say, in this dose range or open label extension trial too, is that 37 of those patients had at least 25 weeks of Joenja, with 2/3 of them being 96 weeks or more. So at 96 weeks, we're nearly up to 2 years. And when we look at the overall, it was 2 years on average, with 4 patients really driving a lot of that up at 5 years or more of the investigational medication. And when we look at more of the open label extension data, which hasn't been published yet, but this has been analyzed so far, we do see that the annual reported rate of infections, or the infection days in a year, does decrease over time and over the reported time frame of the open label extension. And this is as part of the trial. They had to report every single time they had an infection. So that's where this data came from. And then the physician reported immune immunoglobulin replacement therapy reductions and discontinuations. Discontinuations or reduction was not part of the clinical trial plan, but it did happen in some patients and it was observed. And what they observed is 6 patients were completely free of immunoglobulin replacement therapy at when they checked in with open label extension. 3 had a significant reduction at about 50%, and 1 had it reduced by about 37%, or about 30%. And so when we look at this overall and we add up these 10 patients, it gets to 37% of these patients receiving immunoglobulin replacement therapy had a reduction or discontinuation of the IgG replacement therapy at that time. And at the data cutoff, 4 of these patients had been free of IgG replacement therapy for 1 to 2.5 years. So a bit of time. Now, when we look back at this individual patient that was reported, we look at her baseline for this study, and that her naive B cells were decreased at baseline, and that her plasmablasts were also increased. And we see her IgM, and we see her T cell studies here too. Then we see at 12 weeks of the trial that her baseline naive B cells increased, that her plasmablasts decreased, and her IgM decreased, and that her T cell subsets started to normalize too. Her lymphadenopathy decreased by 40%, her spleen decreased by 38%. Again, these aren't averages, this is this particular patient and what her results were. She did have an aphthous ulcer, and this is an example of one of the grade 1 adverse events. And it was potentially related to treatment, and that was from day 16 to 51, but then it disappeared at that point. With this patient, when we're thinking about her, she's a patient with APDS on Joenja now. How would we continue monitoring this patient? Or how would you, I should say? I think it's kind of all over the place. I think this is good because I have to be honest on this one. I would say I don't know that there's a right answer, and I think you could get a bunch of us in a room and we could have a lot of debate about the right answer is. And I think a lot of us would be right. And so a lot of considerations continue to monitor her for lymphadenopathy, splenomegaly, monitor for malignancy, and the immune subsets, look for bronchiectasis. All of these things we need to continue to pay attention to while on the Joenja and continue to treat her underlying disease. All right. So when we look at this, we talked about genetic testing, and it is important to note that access is a big issue with genetic testing. However, eligible patients can be tested at no charge through Navigate APDS. It's a program that has been set up with the folks at Farming, and what you do is you sign in, if you have to have an Invitae account, and then you go to account settings, orders and reports, and then you can create a new account and all of that. Then you start an order, and there's an option when you start an order for collaborative testing and no charge sponsored testing. It's really easy. You just go in and search APDS, and this comes up, and then you pick your panel, the Invitae primary immune deficiency panel, or there's an inborn error of immunity and cytopenia panels. A little bit of differences between them, and you have to look to see all the differences. It's a whole talk on its own to talk about that. And you add it to your cart. You fill out everything, and they also have genetic counseling offered that's sponsored. In one of the pages, there's just a box you click to say, hey, yeah, I'd like help of a genetic counselor from Invitae to help me with these results. And then you submit it, and it can either be a blood test or they'll send a buccal swab kit to your patient's house too if you want to make it as easy as possible. When we talk about this is APDS Assist, they really have tried to come up with everything to make the process of once we identify a patient with APDS and we decide we want to treat them with Joenja, how do we make this easy? And I think that they've thought about a lot of steps and really every step to do that and to make it easy. They have a single pharmacy, a single point of contact. There's every time you call them, it's going to be the same person. It's the same person you call, it's your patient's call. They have a dedicated pharmacy staff. The pharmacy staff is very knowledgeable about this medication and how to do it and all of that. They provide assistance and support with prior authorizations, which is just huge. They have set up a starter program for 30 days of free Joenja for eligible patients at no charge. And then they also have patient support services to make sure that all the eligible patients have access to it. So they have, with this includes the APDS care coordinators, the clinical educators to help provide support to your patients, and then the specialty pharmacy and those specialty pharmacists too. And really to bring it all home is Joenja targets the mechanics of APDS to help restore immune balance. And it has been shown to have significant reductions in lymphadenopathy. And it has significant improvements in the immune dysregulation, and that's as measured by the lymph node and spleen reduction. And they have at week 12 of the pivotal trial, the reductions as we talked about, and 27% in the lymphadenopathy, and then 46 to 5%, depending on how you measure it. Significant improvements in the immune phenotype. And so we have an increase in the naive B cells versus placebo. Then we look at observationally, there also was observed the normalization of the IgM levels that really needs to be looked into more, but should be emphasized. There's no serious adverse events were reported. No patient withdrew from the trial due to adverse events. Most common things, headache, sinusitis, and atopic dermatitis. And then the open label extension, the data was pulled in December 2021 across all trials. 97% of the patients had been on for at least 25 weeks, with 2/3 of them being for 96 weeks, and then 4 patients have been up to 5 years. And we really want to emphasize this because I don't know about you guys, but for me, whenever I have a new medication I'm discussing with the patient, that's one of the questions they ask is, well, what experience do we have with it? How long have patients been on it? How confident are we in with the data? And I think this is really confident data, at least for me personally, for a new medication. And then this post hoc analysis also showed that the days spent with infection and had decreased, and the IgG replacement therapy also had decreased and was discontinued in some patients.
All right, with that, Dr. Hartog and everybody that attended, on behalf of Farming, I want to thank all of you. Appreciate you joining this evening. Dr. Hartog, great job going over all the slides this evening with everybody. And I hope you all have a wonderful evening.
Thank you, everyone.